Good afternoon. Welcome everyone to the Senate Committee on Health and Human Services. Madam Secretary, please proceed to call the roll.
Senator Lang. Here. Senator Wynn. Here. Senator Stone. Here. Senator Titus. Chair Donate.
And I am here, and please mark Senator Titus present when she arrives. Good afternoon, everyone, and welcome to today's committee meeting on Health and Human Services. Today we have a few bills to present, and we have AB 100, 114, 132, and 154. The order of today's agenda will be AB 100, followed by 114, 154, and then lastly 132. Again, just wanted to clarify that for folks because agenda items may be taken into a different order. We are experiencing a few technical difficulties with Zoom connection, so we may have to pause depending on how far the meeting goes. But for right now, that's the order that we have. I do have a couple of housekeeping announcements for folks. We asked that public comments today be made to 2 minutes each so that everyone interested in speaking can be accommodated. And for the sake of time, we ask for folks to not keep the bill presentations longer than 10 minutes. You may also submit your public comments in writing, either in addition to testifying, and you can provide that to our committee staff. If you do not testify, you can also sign in at the front, so that way we can capture who's here in the room. And when testifying, obviously, please make sure you turn on your microphones on to speak and off to listen. Anyone who wishes to receive copies of the committee's exhibits can go to the Nevada Legislature's website. And finally, we ask everyone to please turn off their electronic devices. At this time, I will go ahead and open the hearing on Assembly Bill 100. This bill provides for certain assessments relating to caregivers, and I am going to go ahead and turn it over to Assemblywoman Brown-May to present this bill.
Thank you, Senator. Members of the committee, Tracy Brown-May, for the record, proudly representing Assembly District 42. We are very pleased to be here today. This is the second time I have the honor of presenting this bill, which I think is going to do some really wonderful things. Joining me today is Molly Walt. She is the chair of the Nevada Lifespan Respite Care Coalition and CEO of the Nevada Rural Counties RSVP program. This bill originated out of the good work of that coalition. So at this time, I'm going to turn it over to Molly to allow her to introduce herself and talk about the background.
Thank you, and good afternoon, Chair and members of the committee. My name is Molly Walt, Chair of the Nevada Lifespan Care Coalition. I'm honored to be here to present Assembly Bill 100, and I thank Assemblywoman Brown-May for sponsoring this bill. And the coalition represents respite from Nevada's private and public sectors as well as family caregivers. Our mission is to support caregivers by promoting awareness of, access to, and coordination and advocacy of respite services in Nevada across all disabilities and throughout the lifespan. Respite care should be a typical experience and valued service designed to fit the needs and choices of consumers. Nevada does not have a system to recognize caregivers' goals. No assessments to address the health and well-being of the family's caregivers, even a logical point such as hospital discharge planning. This bill is the first step to getting us there.
Thank you. Tracy Brown-May for the record. The data is necessary to determine the quality of care that we have that our caregivers are able to continue, and currently there is a significant lack of data. The needs, the quality of life of our family caregivers. The lack of all of that information prevents the implementation of wraparound support services to help folks remain in their homes. This bill requires the Division of Aging and Disability Services, the Division of Health and Human Services within the state of Nevada to create a caregiver survey, which has been done in numerous other states, and then to deploy that through a pilot program for the individuals that are receiving services through those waiver programs currently. So we've pared back the original bill to be a very targeted pilot program for all of the folks currently receiving waiver supports out of the Division of Aging and Disability Services so that we can create and validate a caregiver study that then potentially we could deploy even farther once we identify what the right survey tool is. The Division of Aging and Disability Services representative is currently at the Grant Sawyer Building if you have additional questions. Talking about the potential fiscal notes associated with this, realizing this is the policy committee, the division significantly pared down the original fiscal note to something that was very manageable, that they felt they could handle through an easy grant, and that identifying the capabilities of our family caregivers is essential. On a personal note, this really comes from the many family caregivers that I have the opportunity to work with every day. Moms and dads of adult children with significant disabilities that are the primary caregivers. The chair people and volunteers of Molly's organizations and the people that she works with that we just don't know are out there. My mom is an Alzheimer's patient. She has advanced stages of Alzheimer's. My dad is 90, and he is her primary caregiver. If something happens to my father and we don't know where he is, no one knows to look for my mother. Now, they don't live in Nevada, so this is not going to directly affect them, but there are many families just like mine across our entire state, and identification of who they are and what they need to stay in their homes safely with the right support services decreases the cost associated with long-term care supports in other settings and improves the quality of life of all of our residents. That is our bill. We're happy to stand for questions.
Thank you so much. Any questions from committee members? Senator Stone.
Thank you for the presentation, and I certainly appreciate the scenarios you talked about, and Godspeed with your parents. So if anybody's receiving HHS funds today, they're going to be, is this voluntary or is this mandatory that they have to be a part of this survey?
Tracy Brown May for the record, through you, Chair, to Senator Stone. Thank you for that great question. It is clearly voluntary.
Okay.
It is a tool that the Division of Aging and Disability Services will develop and then offer to all of the folks that are receiving support services through their divisions. No one would be mandated to participate, although we would encourage folks to be a part of the development of this tool to help us develop better services.
So if I can continue, so this is basically going to help better educate the caregivers that maybe don't have any kind of discipline for caregiving, and making them aware of maybe county services that are available, federal services that are available, in-home supportive services. People don't even know, I'm surprised in this state, a lot of people don't know that even exists, these federal funds that can help them out. So I assume once you get done with the study, then this will be disseminated on your website and maybe emailed to many providers that sign up for getting this valuable information once it's tabulated.
Thank you, Tracy Brown May for the record, through you, Chair, to Senator Stone. Thank you again for that question. You are correct. The way that this is designed and is written in this bill, that any entity that receives funding from the Division of Aging and Disability Services or Health and Human Services in the state of Nevada would be offered this tool to be able to deploy to the populations that they serve. That's who the initial target population will be. We can imagine that once the data is available, then internally we'll be able to look at what are the results to identify the needs that are not currently being met. It'll give us an opportunity to rewrite our waiver support services and then to direct the folks that are engaged in this pilot program additional services, as you've noted, that could potentially be federally or other state funding options.
Thank you.
Thank you so much. Any additional questions? I have just a quick comment, and you can respond to this as well. So I think the piece of legislation you have is very timely, and it's important to have that conversation. I know in the primary care facility that I work with in geriatrics, we have family caregivers that don't get compensated for it, and they pick up the mantle sometimes. And the situations that we've had is, because by nature of society, we have to work 40 hours a week to pay our bills. But it's also a full-time job to take care of our family members. And what happens in some situations, which is what we've seen, is when you have certain family members that are in charge with taking care of their relative that is older, or perhaps they're dealing with a disability, etc., that there's not enough training to understand what is the actual requirements that you have to do to take care of them. It's not just taking care of them and feeding them any type of food. If they have a feeding tube, etc., there are certain things that you have to be aware of as to how you maintain their sanitation, how you can help them exercise so that they can retain their mobility, etc. I think there's, for me particularly, when I saw this legislation, I was hesitant as to why the study was needed, because I think you can accomplish a lot of this simply by just revising the definition of caregiving and making sure folks are compensated. But I think what you mentioned in your testimony probably switches my perspective, because you are correct. There are wraparound services that we don't know of what could exist today, but we have to do a comprehensive analysis to feed those gaps. And so my hope would be that at some point in the near term, and perhaps we could do this in the interim as well, is we come back with a money request and we say, this is important. There are folks that are caregivers to children and to their senior relatives that do this full time. That is a job, and they should have an obligation to get some sort of benefits for the services that they do, and they should be compensated fairly so that they don't have to work multiple jobs or go back and forth as to what it means to even just take care of your family members. So I don't know if there are conversations that existed for you before you introduced this bill. I saw the reprint, but maybe if you can highlight like what other conversations you've seen behind the scenes and what you would like in the long term.
Thank you, Senator Tracy Brown May, for the record. I sincerely appreciate that and the depth of consideration that you've given this particular piece of legislation. In my 20 years in disability support services, I've met with many, many families who tell us what they need to be successful. And I think that's the first thing, is first identifying how do we help families achieve their vision of success. The one thing that I can tell you I know unequivocally is that I don't know. And until we ask the questions of each one of our families in each of their unique situations to determine what are their skills gaps, how do we help them be successful, we're not going to have the answer. So this type of tool helps us to first identify what is our next step. Your point is well taken. My dad loves chocolate and ice cream. If he could eat only chocolate and ice cream, he would do that. But my mother's condition does not respond well to chocolate and ice cream. So she has to have a smoothie with some green spinach in it. But my father doesn't prefer that, so he doesn't make it. If the nurse comes in and knocks on the door, he'll let her in. And then she'll do the things she needs to do in order to care for my mother. My dad is not going to do that. He's going to try chicken soup out of a can. It's not the right nutrition to help her maintain her awareness long term. So I think developing the tool to identify where's the skills gap so that we can further help our families remain in their homes, in their community settings, and maintain their quality of life, the less money it's going to cost us in the long run, and the happier all of our citizens are going to be. Now, the one woman, and I'm going to talk about Cheryl Donnell, is a woman I've worked with for a long, long time. And Ms. Walt works with her very closely. They thought as a family they had it together, okay? Her and her husband have an adult son with significant intellectual disabilities. And the question that most families ask as they have adult children with that type of disability is, what's going to happen to my child when I'm gone? Those families are caregivers. Moms and dads take care of their adult children their entire lives with no end in sight. So most of us have a child who reaches the age of 10 and they can feed themselves. 15 and they are almost going to drive a car. 20 and they're going to get married-ish, hopefully a little later. That doesn't happen for parents of children with profound and significant disabilities who live in their 40s, 50s, 60s, and they will require care their entire lives. Unfortunately, Cheryl's husband recently had a stroke, and now she's caregiving for 2 people. Well, who supports Cheryl, and how do we help her maintain her quality of life in her family so that she can continue to work and support both her husband and her adult child, right? So that's where we're coming from. And as this entire coalition of families came together over the interim and many, many years, they identified the best place for us to start is here with this tool so that we can figure out what families need so that we can then develop the next step, which is the pay piece, the additional wraparound support services, and how do we fund long-term care in our communities. I look forward to working with you on that.
And just as a quick follow-up, so I'm sure you've spent time, because you work in this space, and I'm sure for this bill you researched what other states do. Do other states pay family caregivers to a certain difference so that they can actually do the work that is needed? Is that something that I know our state is missing that, but have other states started to move towards that space?
Thank you, Senator. Great question. Tracy Brown May for the record. There are some states that do that. Nevada has begun to move in that direction. So we do have some instances right now where family caregivers are receiving pay in order to be able to do that. We've worked closely with the Division of Health and Human Services in order to start to step into that arena. And I'm sure that they could respond in detail to the types of programs they have available currently.
Thank you so much. Any other questions? All right, we'll go ahead and move on to testimony and support. If you would like to testify in support of this bill, please come forward in Carson City and in Las Vegas. And as a reminder for folks to keep 2 minutes to their testimony. Ms. Pazinski, we'll start with you.
Good afternoon, Mr. Chair and members of the committee. For the record, my name is Mary Przinski, here representing the State of Nevada Association of Providers, SNAP, and our member organizations that belong to SNAP provide services for the intellectually disabled individuals throughout Nevada. So we're in strong support of AB 100 because we see how important family members are when they are caregiving, especially for their intellectually disabled individuals. Family members play an important role in the continuum of care, and those with developmental disabilities really depend on them. So we think that this bill is going to help us help caregivers, and they in turn then will be able to help those they care for to a greater extent. So we're in support. Thank you.
Hello, Chair and members of the committee. My name is Vanessa Dunn, VANESSADUNN. I am here on behalf of the Nevada Public Health Association, also known as NPHA. NPHA is in support of AB 100, which will benefit both caregivers and patients in Nevada. Thank you for your consideration of this important bill.
Thank you, Mr. Chair and members of the committee. My name is Marlene Lockhart, representing SEIU 1107 and home care workers. We are 100% in support of this important legislation, and we are very appreciative to the sponsor for bringing it forward. Thank you.
Thank you so much. Anyone else in Carson City? Anyone in Las Vegas? And BPS, anyone virtually?
If you would like to testify in support of AB 100, please press star 9 to take your place in the queue. Caller, you were unmuted and may begin.
Oh, yes, thank you so much. My name is David Nichols. I'm representing the board of the Nevada Lifespan Respite Care Coalition. I also am coming from Archwell Healthcare Facility, and I'm 100% in agreement with this bill in support. Thank you.
Good morning, Chair. Good afternoon, Chair and committee members. My name is Dora Martinez, representing the Nevada Disability Peer Action Coalition. We would like to take the opportunity to thank the sponsor for this common sense bill. This will really, truly, absolutely help people who are with disability, and we ditto the prior commenters. Thank you.
There's no additional testimony at this time, Chair.
Thank you so much. Anyone in opposition, please come forward. Seeing none in Carson City and in Las Vegas. BPS, anyone virtually?
If you would like to testify in opposition to AB 100, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. And anyone testifying in neutral on this bill, please come forward. Anyone in Las Vegas and BPS, anyone virtually?
If you would like to testify in neutral for AB 100, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. We'll have Assemblywoman Brown May come back to the table. Go for it.
Thank you so much for the opportunity to present this bill. I'd also like to draw your attention to, there are some exhibits on Nellis that are also in support. We tried to help streamline this hearing in the interest of time, so may the force be with you. Thank you.
Thank you so much. All right, we'll go ahead and close the hearing, and we'll move on to Assembly Bill 114. This bill revises provisions governing the Nevada Early Childhood Advisory Council. Today we have with us Assemblywoman Thomas, so please begin when you're ready.
Good afternoon, Chair Donante and Vice Chair Nguyen and members, committee members. For the record, I am Assemblywoman Claire Thomas, representing Assembly District 17 in beautiful North Las Vegas. It is my pleasure to present to you Assembly Bill 114 concerning the Nevada Early Childhood Advisory Council. Joining me today is Patty Oya, Director of the Office of Early Learning and Development at Nevada's Department of Education, and Denise Tanana, Chair of the Nevada Early Childhood Advisory Council. Before I begin, I would like to point out two exhibits, both of which are available on Nellis. First, you will find the presentation with the overview of the bill, and second, there's a friendly amendment submitted by Denise Tanada. I would like to talk about the importance of early childhood development and the Nevada Early Childhood Advisory Council. Early childhood development refers to the period of growth and learning that occurs in children from birth through age 8. This is a crucial time in a child's life as it lays a foundation for their physical, emotional, social, and cognitive development. Research has shown that early childhood experiences have a significant impact on a child's future outcomes, such as academic success, health, and economic stability. In fact, the first 5 years of a child's life are crucial for brain development, with 90% of a child's brain growth occurring during this time. That's why it's so important that we invest in early childhood development. We need to ensure that children have access to high-quality early learning experiences that promote their development and prepare them for success in school and beyond. For instance, growing research consensus show that high-quality preschool programs prepare children better for school, especially in terms of their academic skill development. Research also shows that modifiable factors in a child's early years can greatly affect the child's health and learning trajectories. We need to support families and caregivers to help them provide a nurturing and stimulating environment for young children. Last year, I, along with Senator Wynn, formed a 4-person Nevada delegation invited to participate in the Hunt Institute Convention for Early Childhood. At that convention, Nevada, along with 49 other states and U.S. territory of Puerto Rico, recognized the importance of high-quality early childhood programs and the need to address the holistic needs of children and families in Nevada. This is where the Nevada Early Childhood Advisory Council comes in. The council is a group of experts from across the state who provide guidance and support to improve the quality of early childhood programs and services in Nevada. Their mission is to promote a comprehensive, high-quality, coordinated system of early childhood services that support the development of young children and their families throughout Nevada. The council works to strengthen state-level coordination and collaboration that support early childhood development, such as increasing access to high-quality early learning programs, supporting the professional development of early childhood educators, and advocating for policies that promote family-friendly workplaces and support for working parents. Now I will hand it over to my 2 co-presenters who will provide you with more details of the council and the overview of Assembly Bill 114.
Thank you, Assemblywoman Thomas. Are you going?
No, go ahead. I wasn't sure if the Zoom was working.
Please proceed.
Thank you. Patty, do you have the presentation?
This is
Perfect.
Patty Oy for the record. Yes, it's up. I'm not sure if they can see it, Denise.
Please proceed.
It's up on the...
Can you see the presentation?
Yes, we can. Please proceed.
Perfect, thank you. Hi, for the record, my name is Denise Tanada. I currently serve as the Early Childhood Comprehensive Systems Director at the Children's Cabinet, and as Assemblywoman Thomas indicated, I also currently serve as the Chair of the Nevada Early Childhood Advisory Council. Today we're going to go rather briefly. I'm going to give you just a high-level overview of the Early Childhood Advisory Council and some of the work that we've done that's led to these recommendations. And then I will pass it over to my colleague Patty Oya, who will provide a summary of the bill as well as the fiscal note from her office. Next slide. This slide just provides a brief overview of the history of the Nevada Early Childhood Advisory Council, which was actually originated from the Federal Head Start Reauthorization Act in 2007. The council was created originally in Nevada by executive order in 2009 and eventually established in NRS in 2013. With the Head Start Reauthorization Act has the same mission and vision purpose that Assemblywoman Thomas went over in her opening remarks. Next slide. But overall, the purpose of the Nevada Early Childhood Advisory Council, as defined in NRS 432A.076, is to work to strengthen state-level coordination and collaboration among the various sectors and settings of early childhood programs in the state of Nevada. Next slide. NRS 432A.076 provides that membership of the council must be appointed by the governor. We currently have 12 delineated membership positions, which we identify as seats A through L, and one category that includes such other members as the governor determines appropriate. We currently have 19 members and one vacancy, which is our pediatric healthcare provider position. 7 of those members are in the other members category. Next slide. In 2021, the Early Childhood Advisory Council underwent an extensive process to develop our 2022-2024 strategic plan. And this process included input from over 150 key stakeholders throughout the state of Nevada, including our ECAC members, early childhood systems partners, providers, as well as parents and community members. And the strategic plan really moves the focus for the Early Childhood Advisory Council away from the programmatic level to really looking at improving our comprehensive early childhood system, prioritizing coordination and alignment across the sectors of the early childhood system. Our key goals, objectives, and activities were also developed in coordination with related initiatives, including our HRSA Early Childhood Comprehensive Systems Grant, the Pritzker Prenatal to 3 Initiative, and the Preschool Development Birth to 5 Grant, among others. And as such, we've defined early childhood as the prenatal period to age 8, which encompasses access to nutrition, healthcare, mental and behavioral health, protection, play, and early learning to stimulate children's physical, cognitive, linguistic, and social emotional development, really taking a holistic view. And similarly, the early childhood system includes all of those agencies, organizations, programs, and infrastructure needed to provide those services. At this time, I would like to hand over the presentation to Patty Oya, and just wanted to highlight as well that the recommended changes to the NRS that we're presenting here have been recommended and approved by the Nevada Early Childhood Advisory Council, and were also included in our annual report to the governor and legislature on December 1st of last year. Thank you.
Good afternoon. Thank you. Patty Oya, for the record, OYA, Director of the Office of Early Learning for the Nevada Department of Ed. The reprint for AB 114, it removes the word education and changes that in all language to early childhood program. We feel, as we're talking about comprehensive services to young children, it's not just about education, which is important, but it is also about mental health, behavior, other services, social services, family engagement. So we wanted to make sure that it reflected that comprehensive view. It also just clarifies language. There is a position, as Denise mentioned, there are, positions listed, and the section 619, our Part B coordinator, is one person in the Nevada Department of Ed. The Part C coordinator is under Department of Health and Human Services. And so this is just a clarification of those two positions. Then sections 1.1 adds 5 new appointed members, Department of Public and Behavioral Health, Maternal, Child, and Adolescent Health, the Program for Child Care and Development under the Division of Welfare and Supportive Services, someone representing public schools serving children in K-3, kindergarten to 3rd, a tribal organization member, and a parent or guardian of a young child. It could be multiple parents representing a diverse background representing in Nevada. The last change is it adds a definition of an early childhood program, any program for children less than 8 years of age pertaining to nutrition, health, care, mental or behavioral health, protection of play and learning to stimulate physical, cognitive, linguistic, social, and emotional development. Again, it's taking that comprehensive view of development in young children. The friendly amendment that was submitted with this presentation is, again, just a clarification of the 2 roles under the one under the Department of Ed and one under the Department of Health and Human Services. The Part B coordinator is under the Department of Ed, while the Part C coordinator is under Health and Human Services. And the fiscal note, while you'll see that it's a $0 amount for the next 3 fiscal years, we did add, and then with fiscal year 27, that is for two positions to support the council, the work of the council. They would be under the Department of Ed. Currently, they are being funded through the federal preschool development grant that the state just received. And so that is why there's no fiscal note, but at some point, we would like to continue those positions once the grant ends in December 31st, 2025. And then we have our contact information. So we're happy to answer any questions. Thank you.
Thank you. Thank you, Chair.
Thank you so much. Questions from committee members? Senator Titus.
Thank you very much for the presentation, and certainly appreciate what you are trying to do and the issues you're trying to solve, because indeed, we need to capture these as early as possible to make a difference. I'm curious, it's a current commission already, so this committee's heard my frustration about creating new commissions and new committees and all these new studies, but this is in existence. You're trying to actually improve it so that it may actually, not that it hasn't done good things now, but actually address some of the concerns and maybe actually get some solutions. My question is, are all the positions currently available under this council filled? Because you're adding 5 more apparently?
Assemblywoman Claire Thomas, for the record, through you, Chair, to Senator Titus. Yes, those positions are filled. What we want to do right now is to inject the early childhood experts in there, because right now there are none.
Thank you for that. I just wanted to make sure that it can function. You're adding more positions appropriately. I mean, I see why you're adding them and certainly are supportive of that. Just wanted to make sure that so many times we hear that the commissions haven't met, they're not functioning, they can't find people to sit on them, and just wanted to make sure this is a ready functioning, and all you need to do is some more input from different levels. Thank you.
Yes, ma'am.
Vice Chair Nguyen.
Thank you, and thank you for that presentation, Assemblywoman. I'm really excited to have you presenting. I know that seeing kind of our group back together from the Hunt Institute, it shows what can happen when we work across different agencies and get different voices, and also utilize those services that are out there in the community and around the country to see what works best. So I think adding the voice of this particular sect and how that interplays when children ultimately are in our elementary schools and high schools is just so crucial. So I'm completely supportive of the bill. Thank you.
Thank you, Vice Chair Nguyen. Any other questions? All right, we'll move on to testimony in support. If you are here to testify in support of this bill, please come forward. And we'll ask the presenter to step back in Las Vegas so we can have folks come forward as well. Mr. Clark.
Good afternoon, Mr. Chairman, members of the committee. My name is Tom Clark. I'm here on behalf of the Children's Cabinet. The Children's Cabinet does a lot of work with the ECAC. And to Senator Titus's question about new boards and new commissions and what ones are working and what ones aren't, this is definitely one that is working. And the injection of these additional positions is only going to make it better. We very much support it. Thank you.
Good afternoon, Chair Donate and members of the Senate Health and Human Services Committee. My name is Sheila Bray with the University of Nevada, Reno. We would like to express support for Assembly Bill 114 and thank Assemblywoman Thomas for bringing forth this bill. The outline changes add in vital and necessary members to the Nevada Early Childhood Advisory Council. We know how important early childhood education is for the growth and development of our young people. As an institution of higher ed, we appreciate the bill sponsors cohesive expansion of this council to best represent the array of needs, skills, and development necessary for our early childhood members, as well as all of those that she added in that would also speak to the training and professional development for early childhood professionals. We thank you for hearing this bill and urge your support.
Thank you so much. Anyone else here in Carson City? Let's go to Las Vegas.
Good afternoon, Chair and members of the committee. My name is Jamel Nance. I'm here today representing the Children's Advocacy Alliance in support of AB 114. This bill is one that is really near and dear to our hearts. This is one that really is important to us because we believe in the diverse representation of the members of the Nevada Early Childhood Advisory Council that reflects the true representation of the systems that really impact our children. And so we know that that extends beyond education, like with entities as Denise and Patty presented, that includes our healthcare providers, our mental health providers, and certainly, most importantly, our parents. I would like to reiterate the importance of ensuring that as this advisory body makes recommendations on the needs and resources for our young children and families, that we have the right people at the table, and I believe that AB 114 does just that. Recommendations cannot be made adequately or equitably without the individuals who represent the entire early childhood system and the issues that it aims to solve. It is my hope that you will vote yes to the provisions outlined in Assembly Bill 114. Thank you so much for your time.
Thank you so much. Anyone else in Las Vegas? BPS, and is there anyone virtually?
If you would like to testify in support of AB 114, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Let's move on to opposition. Is there anyone in opposition to this bill? Seeing no one here or in Las Vegas, BPS, and is there anyone virtually?
If you would like to testify in opposition to AB 114, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. And anyone willing to testify in neutral on this bill? Seeing none here and in Las Vegas, BPS, anyone virtually?
If you would like to testify in neutral for AB 114, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Assemblywoman Thomas, do you have any closing remarks?
Yes, sir. Thank you, Chair. I just want to say in closing, Assembly Bill 114 ensures that the Council's critical work continues so that all children in Nevada have the opportunity to reach their full potential. And I would really greatly request that you support this bill and pass it. Thank you so much.
Thank you so much. At this time, we'll go ahead and close the hearing on this bill, and we will move on to Assembly Bill 154. This bill provides for the regulation of the living donation of birth tissue. We're going to take a short recess to wait for our bill sponsor to arrive. All right, we're back from recess, and Chair Peters, whenever you're ready.
Thank you, Chair Doñate and committee members. It's wonderful to be over here in the Senate. This is my first time this session over here. So I appreciate the opportunity to present to you Assembly Bill 154. I'm going to do just a quick intro and we can jump into questions. This is a relatively simple bill that addresses an issue of education. I've been pregnant 3 times and had 3 live births. And in each of those situations, learning about what is real and what's available for a person who's pregnant is a challenge. There's so much misinformation out there, and there's so many people who can take advantage of you in a vulnerable time in your life, that knowing what's real and what's not can be really problematic. This bill looks at specifically the donation of live birth tissue, which is part of what happens when you have a baby, right? You have some extra tissue that comes out, an extra organ that comes out, and that can be used in a donation for other vital services, right? You can find all kinds of other information out there about how you can handle that tissue or what you can use that tissue for. But what we wanted to do was make sure there was a safe place for birthing people to go for information on how to donate it to a safe and reliable donation center. So AB 154 in its first reprint requires that I think it's the Division of Public and Behavioral Health. Yeah, the Division of Public and Behavioral Health maintain a website that just lists those entities that are accredited tissue banks and can accept birthing tissue, and requires that that list be available to birthing people in specific settings through a link to that list. And this would be updated regularly and periodically, and ensure that these accredited entities are meeting specific standards, so women birthing people have a place where they know that what they're looking at is accurate and accredited. So that's what the bill does. I stand for questions.
Thank you so much, Chair Peters. Any questions from committee members? Any questions? No? Going once? Vice Chair Nguyen? No? Senator Stone. There you go.
Thank you, Mr. Chair. Thank you for your presentation. And there's a lot of wonderful life-saving elements that come from these organs, namely stem cells. And I think it's important that women know in advance of their births where they can send these tissues so that they can help other people. But can you just tell me about these banks? Are these nonprofit banks? Or are they for-profit banks? And how do they distribute the cells? And do they go to drug companies, or do they go to research? Or can you just elaborate on that for me?
This is a great question, and I'm going to call a friend, Sarah Peters, for the record. We have someone down in Las Vegas, I believe, who can answer what the tissue banks that are accredited under the specific accreditation organization and its successors can do with birthing tissue.
Hi, thank you for your question. Dan Lund, Vice President of Tissue Operations for Nevada Donor Network. The tissues are used by tissue processors that utilize the tissue for wound treatment. It's in many cases where treatments have not been able to be identified. This placental tissue actually is utilized for wounds and has many, many successful outcomes. That is also, in addition to wound treatment, there's also uses in dental procedures, sports medicine, ophthalmology, but it's really a new and exciting area of tissue banking, and it's just a great thing for not only the state of Nevada, but also moms to have this option of donation.
If I can just follow up, who regulates the tissue banks? Is it the state or is it the feds?
Dan Lund again, Vice President of Tissue Operations, Nevada Donor Network. The Food and Drug Administration is the regulatory body for tissue banking.
Thank you, and thank you for your service in helping people out with some of these critical needs. And I appreciate the author for bringing it forward.
Thank you so much, Senator Titus.
So thank you for that. And why we have you there. So I have delivered hundreds of babies, and always at the time of delivery, after you deliver the placenta, you evaluate it, making sure it has the proper vessels in the cord, making sure, looking at any infarctions or disease process, all of those things. But certainly nothing that would prohibit it then and we would send it as a tissue specimen, right? So then we get the path report back on it. We wouldn't throw it away per se. Ultimately, then after the pathology was done, they would destroy it. So I think good policy, but certainly at the tissue banks, they too would, I can't imagine that it would be donated prior to doing that basic examination to making sure it was a healthy placenta.
Sarah Peters, for the record, this is a really good question because I wondered, like, in what scenarios can this birthing tissue be collected initially, right? Because there are different scenarios in which birthing happens, and so there are specific qualifiers at this time that result in the accreditation of the tissue for that particular donation process. I don't know if you have additional information on those specifics. I know cesarean sections were one situation in which you could collect that donation tissue, but I would defer to the experts on the additional criteria.
Dan Lund, Nevada Donor Network. Thank you for the question. The physician is really going to determine whether or not if there were problems during childbirth, problems that the physician feels that require a need for the placental tissue to be go to pathology or for further testing. That would actually come first before the tissue could be used. And if the physician deems it needs to be used for those circumstances, that would take precedence over the donation itself.
And follow up, if I might, Mr. Chair. And along that same line, so we've had a lot of discussion this session regarding home births, midwives, et cetera. And looking at somebody who is doing a home birth, is there a pathway that they can connect to proper storage and salvaging of this birth tissue?
Mr. Lund, do you want to respond to that?
Yes, Dan Lund, Nevada Donor Network. Currently, there does not exist a pathway. We have been primarily working with hospitals, but it's not to say that isn't a pathway that couldn't be further explored or developed.
And if I may, Sarah Peters, for the record, we very specifically, based on input from the midwifery community and the home birthing community, and requesting to not be included in the obligation to present this information to their patients because of this limitation of not really being able to provide that service directly to a tissue banking entity. We specifically called out that hospitals or birthing centers were the only places in which you would have to present this information to a patient because they would be the most likely to be in a scenario where it could be collected for tissue donation.
Thank you. I just didn't want somebody showing up with their placenta in a bag to the hospital saying, hey, I have it, right? Saying.
Thank you, Senator Titus. I think you bring up a good point. You know, as when I was reading this bill, I know I have a family member in California that did a similar process, and I know there's a national certification for, I believe it's, hold on, I want to make sure I get the term correctly. You can get certified in placenta encapsulation, so there is a procedure for it. And I think that's, your bill probably opens up for follow-up steps past once this bill gets implemented as to what this ecosystem could look like, but to the point being, so. Chair Peters, did you want to say?
Sarah Peters, for the record, I actually did that with all three of my placentas. I had them encapsulated by a local woman who is a doula, as well as she was training in midwifery, but she offered a processing service, and so I did that with my placentas.
Thank you so much. Any other further questions? Seeing none, we'll go ahead and open up for testimony in support. So if you would like to testify in support of this bill, please come forward now. Anyone in Las Vegas? Let's proceed there.
Good afternoon, Chairman and Senate Committee members. My name is Ashley Ellison for the record, and I am a resident of Clark County and a mother of two-time birth tissue donor. In 2020, I was presented the opportunity to donate my placenta and umbilical cord during my scheduled cesarean section, preceded by my OBGYN, Dr. Sheldon Paul. Prior to this discussion, I was unaware of what the birth tissue process was, and as I had already delivered 2 previous children without the opportunity of donation, and my placenta and umbilical cord were discarded. From my understanding, this is the routine disposition of birth tissue after donation. Dr. Paul explained the process of donation with Nevada Donor Network, and I consented to donate, as the thought of my baby and I being able to help another person in need aligned with my values and beliefs. Prior to the delivery, I was able to complete my consent and medical history via phone from the comfort of my own home. On the day of the delivery, other than a simple blood draw, my experience of donating my placenta and umbilical cord was no different to me as a patient than if I hadn't donated. The only difference was where the tissues were going, and that was to help others. Following my donation, I received an after-donation packet from Nevada Donor Network, which included information about my donation and a little sweet onesie for my newborn. My experience was so great in 2020 that just last year, when I gave birth to my 4th child, I chose to donate again. While our family is now complete, our decision to donate has provided us a lasting legacy of happy times of bringing new life into the world while simultaneously helping save lives and heal lives. I am in support of AB 154 and ensuring a minimal set of standards and regulations for birth tissue donation in Nevada and increasing birth tissue donations awareness for accepting mothers across the state. Thank you.
Thank you so much. Anyone else in support in Las Vegas, please come forward. See someone else? Please begin when you're ready.
Hi, yes, Dan Lund, Vice President of Tissue Operations with the Nevada Donor Network. Very appreciative of Assemblywoman Peters' commitment to organ and tissue donation. We believe that AB 154 provides the information that expectant mothers should have so they can make informed decisions regarding their birth tissue. Thank you.
Thank you so much. Anyone else in Las Vegas in support? BPS, anyone virtually?
If you would like to testify in support of AB 154, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Let's move on to opposition. Anyone here in opposition to this bill, please come forward. Anyone in Las Vegas? And anyone virtually?
If you would like to testify in opposition to AB 154, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Anyone willing to testify in neutral on this bill, please come forward. Seeing none in here or in Las Vegas, BPS, anyone virtually?
If you would like to testify in neutral for AB 154, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Assemblywoman Peters, did you have any other closing remarks? You're good? All right, we'll go ahead and close the hearing on this bill. And then, which brings us to our last bill hearing, Assembly Bill 132. I'll go ahead and open the hearing on this bill. This bill establishes provisions relating to the review of opioid overdose fatalities. We have with us Assemblywoman Cohn, so please begin when you're ready.
Good afternoon, Committee Chair Leslie Cohen, representing Assembly District 29. Thank you for hearing AB 32 and hanging in there with us this afternoon. Presenting with me is Trey Delap from Group 6 Partners. Mr. Delap has worked with in behavioral health, addiction, and recovery policy for years and specializes in advocating in the spaces where they converge. The opioid epidemic has swept through the country, causing death to people in all walks of life, regardless of age, religion, education, race, social standing, and the like. And now, as we'll detail more thoroughly, fentanyl has caused a bad situation to be even more dire. Overdose fatality review has been found to be successful in assisting with providing for the data necessary to curtail opioid overdose deaths. 12 states utilize OFR, and it's considered to be part of best practices. When we began this process to introduce overdose fatality review to Nevada through this bill, we initially thought the review would be most effective and similar to the Suicide Review Committee currently housed in DHHS. However, per the CDC and Bureau of Justice Assistance of the Department of Justice, we found that best practices require more flexibility than the Suicide Review Committee structure allows for. Moreover, as we have proceeded and consulted further with recovery community and stakeholders, we have determined that the overdose fatality review may be more effective by focusing on work to be done at the local level. So as such, the first reprint allows for the sharing of data with agencies and institutions throughout the state at a more local level. So because of the amendment to the bill, some of the agencies were not aware of the bill's requirements until the last couple of days, and we've met with them to try to come to an agreement. After negotiation, we'll be taking out any requirements for police agencies to provide data, and we'll continue to negotiate with the other entities that are in opposition. We appreciate that the chair offered to allow us to have the hearing regardless of the opposition, and that we can continue to negotiate. But as Mr. Delap was only here for yesterday and today, I thought it was best that we, get the hearing now because he's the expert in the field, and I want to make sure that your questions can be answered with him here in person. So with the opioid fatality review, I just want to give some examples of what this allows local agencies to do. It allows them to use data constructively and at a local level to immediately address issues with opioids. So in other jurisdictions, for instance, Indiana has used this very effectively in a couple of different ways. Locals, authorities saw that there was a spike in overdoses occurring, and they were able to respond quickly, making sure that naloxone was available in the area, thereby saving lives. Also in Indiana, a group of 3 counties utilized data that they used through their review to determine a trend of deaths occurring after people were going to the dentist. Not one dentist, it wasn't one dentist who was a bad actor, but it was multiple dentists who were giving out prescriptions. As such, the counties were able to provide training to the dentists regarding substance misuse risk screenings, thereby breaking the trend. So the key for OFR is to allow local agencies and institutions to have access to data with enough time to be responsive where you see hotspots. So with that, I will turn it over to Mr. Delap.
Thank you, Assemblywoman Cohen, Chair Doniate, and members of the Senate Health and Human Services Committee. Chair Delap for the record. Thank you again for allowing me to present to you today. Overdose fatality review is a locally based multidisciplinary process of understanding the risk factors and circumstances leading to fatal overdoses and identifying opportunities to prevent future overdoses. The basis of OFR, like all fatality reviews, is that overdose fatalities could have been prevented with the right action, timing, intervention, and/or response. Overdose deaths can be prevented with 4 key capacities: to coordinate prevention strategies with timely implementation of evidence-based interventions, community mobilization, and engaging supportive families and friends. The shared understanding that overdose deaths are preventable guides the entire overdose fatality review process. Federal agencies such as the Bureau of Justice Assistance and the Centers for Disease Control and Prevention are strategically coordinating to mobilize local communities to develop and implement OFRs throughout the country. One of several programs in Nevada using federal grant dollars to combat the opioid epidemic is the Nevada Overdose to Action, or NVOD2A. Focused on examining data on overdose fatality, they found that 77% of decedents had at least one potential opportunity for linkage to care prior to death or implementation of a life-saving action at the time of overdose. These potential opportunities were recent release from an institution like prison, jail, treatment, or a hospital within the past month, a previous non-fatal overdose, mental health or co-occurring diagnosis, prior treatment for substance use disorder, bystanders present when fatal overdose occurred, and fatal drug was witnessed. In 2021, illicitly manufactured fentanyl, IMF, was present in 1 in 3 overdose fatalities. 81% of overdose deaths occur at home. With thorough analysis, opportunities for resource deployment reveal themselves, but 2 problems remain. Data is so delayed that it is forensic rather than actionable, and the prevalence and potency of illicitly manufactured fentanyl has led to dramatic and sustained spikes in fatalities. The solution is to engage a robust OFR at the community level comprised by stakeholders active in opioid response already, with the capacity to advocate or implement effective interventions to support and empower them to ensure public health responsiveness likely to have the greatest positive impact on their constituent population. Nevada is diverse, and a single response to opioid fatalities is not likely to be culturally competent or in a top-down approach. 3 of the 4 core actions OFRs may address are community to family based. The aim of AB 132 is to empower and engage appropriate local agencies to conduct OFRs and craft, implement, and evaluate community responses. To optimize OFRs, AB 132 grants access to vital information to collect and conduct the OFR. Sections 2 to 5 outline the OFR process. Sections 3.5 and Section 4 detail the duties and accountabilities of the competent and capable agency. Section 5 details the extensive confidentiality requirements. By allowing for opioid overdose fatality reviews to be conducted by a variety of entities, AB 132 can help identify patterns and trends in opioid-related deaths that can inform prevention and intervention efforts. AB 132 ensures that these reviews are conducted in a transparent and accountable manner, with results and recommendations made available to the public, with the expressed and exclusive purpose of public benefit to prevent future overdoses. The review process is separate from and independent of any investigations or reviews required by law, which means that it will not interfere with law enforcement efforts to investigate and prosecute crimes related to opioid use. The confidentiality measures included in AB 132 ensure that sensitive information is protected while still allowing for the sharing of information across entities and agencies. By allowing for access to information from law enforcement agencies and coroners' investigations, the review process can provide a more complete picture of the factors contributing to opioid-related deaths. To be clear, this bill is intended to enable the opportunity for an OFR process to be designed and developed comporting to the best practice guidelines articulated and published by the Department of Justice, Bureau of Justice Assistance, and the CDC. Further, AB 132 mirrors similar OFRs in 12 other states. AB 132 incorporates recommendations from the Attorney General's Substance Use Working Group, SURGE, as well as NVOD2A's OFR pilot project, including leveraging existing fatality review and supporting dedicated fatality review resources, facilitation, and documentation. Research supports the efficacy of OFRs, concluding, overdose fatality review is an effective means of understanding the opioid epidemic, strengthening coordinated interventions, and informing local and state health departments Department Overdose Prevention Strategic Planning. Teams have a unique vantage point from which to view systems-level gaps and policy issues because of their collaborative nature and the quality of data provided by agencies that directly served decedents. AB 132 is the opportunity for Nevada to prevent future opioid deaths by learning everything possible from those who have already passed. With intention, Nevada can expand culturally relevant prevention, intervention, promote recovery, and restore families and communities. Thank you, and may the force be with you. I stand ready for any questions.
Thank you so much. I want to make a statement first, and then I will ask my question, and then I know Vice Chair Wynn has questions, and so does Senator Titus, so we'll go through that, and then if Senator Stone has questions as well. First and foremost, I want to say thank you to Assemblywoman Cohen and your co-presenter. I appreciate your efforts on addressing the opioid crisis. I think many of us in this state realize how much of a pressing issue that is, and we have seen legislation in this chamber and in the other chamber throughout this session to address it. You know, I have the fortune of sitting on the Substance Use Resource Group, and we have had really great progressive discussions as to the settlement money that we're going to be getting and how do we build the infrastructure that we need to really address this complex issue that has been pervasive for many years. And so I appreciate that you have a bill that looks to that nature. Having said that, I think I have been pretty critical in general of legislation across the board of review boards, because I believe, there are multiple groups and diseases that ask of organizations that ask for, we want this review board for this particular outcome and disease. And oftentimes that requires us to mandate reporting mechanisms from our providers to follow through with such diagnosis. I simply believe that we wouldn't need the opportunity to present those bills if we just did one simple thing, which was if we funded public health the way that we needed to and hired the epidemiologists and we maintained a level of interoperability, we wouldn't need the different fatality review boards for particular diseases. Are some of them necessary to look into the biases that we have? 100%. But I think there's a point in time where we have to really consider the infrastructure that we have and what it takes to stand it up. And when we do that, we could save a lot of time just by providing an infrastructure in general for public health. So I guess the question that I have to start us off would be, walk us through what was introduced in the other chamber, the amendments that came through, and what we have in front of us today. I think that would be helpful for us to understand how the bill has migrated to what we have in front of us.
Leslie Cohen, what it started with in the other chamber was more a top-down approach. By the time of the hearing, we did have an amendment that was more, this is more bottom-up. This is more, you find a hotspot at a local level, and you are able to respond to it quickly. So that was what we went with at the hearing. But it wasn't a finalized amendment at the time, it was conceptual.
Thank you.
But, and sorry, Leslie Cohen, and it's because, the concern is we do have mechanisms in the state for data about opioids, where it's supposed to be collected at the state level, but frankly, we're finding that some of that data is not being collected, or I should say not being reported, right? Certain entities that should be reported aren't being reported, and by the time it's being collected, it can be a great deal later, but what we want to be able to do, or we want to enable the right people to be able to do, is react quickly to that hotspot when it happens.
Thank you so much. I understand the sentiments of the gaps that you're experiencing. What I would like to make clear is we're not just seeing that with opioid cases, and that is a systemic public health issue that we're seeing across the board. And so I just wanted to make sure that we were clear on that. Vice Chair Nguyen.
I just have a couple of questions. Again, I'll reiterate, I appreciate you taking on this incredibly complex, incredibly important conversation. I just have some, implementation questions about that, if that makes sense. I noticed in looking at the first version that originally the state board was involved, and it looks like they were taken out as a part of the reprint and the conceptual amendment that took place. And now it looks like it kind of goes to local government entities or institutions. Have they been, I guess this kind of goes to, what kind of criteria are these local governments supposed to be using in making some of these determinations in that section 3.5? And then I have a couple other questions about that. When they're considering on the MOU abilities, because it says in there that they shall not enter into an MOU unless they demonstrate that they are capable of conducting the review and maintaining confidentiality. I guess my question is what kind of criteria should those local governments consider when trying to determine that?
Chair Doñate, trade up for the record, through you to Vice Chair Nguyen. So this is the biggest issue, is a competent, capable entity. So the bill outlines the criteria of the MOU. So basically, the original version, it was almost impossibly vague, and that's the key objective here, is to create an enabling opportunity for someone to do this in a way. So the idea then is that releasing this information or having it go through a process or to a third party, or someone just sort of sets up a opioid fatality review process, they give a letter and then they get all this information, that was a concern because it sort of violates some confidentiality details. So the idea of the MOU was a solution to the vagueness of the problem. Basically, the entities that are detailed, the local entity, the hospital, the provider of healthcare, they default can have access to this. The MOU then is verification that the entity that's going to be doing this has the capacity to maintain confidentiality, perform the actual opioid fatality review, is capable of implementing things that can be implemented, but it holds all of the protections at a higher level at the entity. So the way this would work is, if it was a state or local entity, which could be a county, a police department, the AG's office, they can get it, and then if they have this process. If there's an entity that has an MOU, then the information would go to those entities and not just go into somewhere that isn't safe. So really the design there was to ensure confidentiality, provide for protections of the information, and that the information doesn't go outside of an accountable organization.
And thank you for that. I just have a little bit of follow-up, and that brings me naturally to my follow-up question about regarding that data. I saw, like I said, that you had moved it from that state board into these more local jurisdictions. Is that because the counties and the cities were more willing to be participatory in the process of providing that data for those review committees for those different entities?
Try to do that for the record to Vice Chair Nguyen. In the research, the extensive research on the efficacy of these OFRs in the 12 other states, the most effective and impactful level was at the county level or at the community level. And that's because they can move fast and they can get information that's particularly relevant. The state didn't ask for this and they didn't want it. So originally the idea of going through the suicide review process, all the stuff that was amended out was that the director's office would manage this, that they appoint person, this person, this person, this person, but they didn't want it. There was no funding for it. They had a fiscal note. And so the idea then was, well, also a top-down approach isn't going to work for all of Nevada. It's more important that the people on the ground are the ones that are participating in this process because they will know what the community wants. Also, it removes sort of a mandate because that's the other key here. One of the sources that I used for inspiring this was all these federal resources that are currently issuing grants to the Office of the Attorney General, for example. So this Bureau of Justice Assistance Program, they provide all this technical assistance. With this bill, any entity that would go through all of the extensive work to demonstrate they're capable and competent to do this would be aligned to get all this assistance from federal agency and money like that. So that was the intent, was the local fatality reviews are more effective. They can move faster. And like Assemblywoman Cohen mentioned, this Indiana experience was fascinating. It was an interlocal agreement between 3 or 4 counties that revealed this dental office thing, and no one could have predicted that. So then they know who they are and they can deploy the resources. That's really where this was going and why we took it out of the state.
And go ahead if you want to answer.
Thank you, Leslie Cohen. As Mr. Delap was saying, it's local because you see what's going on. So whether it's someone in the hospital or someone in the health department, when those hotspots are flaring up, they see it. At the state level, they might not see it.
And then I'm just curious about kind of just this transfer of data, I guess, for these review, I guess, I don't know, these fatality review, I guess, committees or entities, I guess, that would be doing this. Would they have subpoena power to be able to get that kind of information, or how does that work? That might be a question for legal. I'm not sure if you have the answer to that or if that was your intention for them to be able to have kind of that subpoenaing power to be able to compel that data if they weren't able to get it. I'm assuming based on the fact that I get the fact that this bottom up is more appropriate, but I'm curious. And it might be a thing for the local jurisdictions if there are anyone in the room here. I see NACO, I think, here.
Trey Delap for the record. I just forgot what I was going to say. Wow.
I think our legal counsel might have an answer.
As far as the question of whether they can subpoena, under Section 5, subsection 1, paragraph C of the bill, yes, they are authorized to petition a district court for the issuance of a subpoena, and then the district court would be authorized but not required to issue the subpoena. So that's how it works in the bill.
I finally remembered what I was going to say. Trey Delap for the record. So one reason for this extensive language is to provide legislative authority for the agency to release the information. That's why, so all these agencies have this information. It's presumed that it's private, confidential, and maintained confidential. Then they need the authority to share that information with someone else. And the bill would enable them to have statutory authority to share this information. That's why the expressed narrow focus is so important. So think of privacy and confidentiality as normative values in healthcare. Privacy is an inherent right. Confidentiality is a system of maintaining it, right? So when you're dealing with public health versus public safety, it's more important that you know everything you possibly can in order to provide the right kind of care. And we will relax our privacy rights in order to help the better whole, to prevent future overdose deaths. And also, so that will give the OFR the ability to look at everything as much as they can to identify potential opportunities to act, and extensive capacity and requirements to maintain confidentiality. One key detail that's consistent in this bill and in other states is this information is for sacred purpose only. It is not discoverable for criminal investigations. It's independent of a investigation. It is not discoverable for civil issues. Also, anyone participating in one has a civil immunity as long as it's genuinely connected to the express purpose. So I hope that helps, that the purpose is to very focus that this information will maintain forever in confidentiality. In the MOU, even if it was a university study, it was important to include that forever and ever this information is held confidential and private, and only the result reports. And here's something that's important for Nevada. The OFI, Office of Public Health Information, has some mechanisms where they look at health data and statistical data where if it's going to be identifiable, because the population is so small that if it's Lander County and there's 3 people, you can figure out who it is. So they've done some stuff to modify how the data is aggregated, recorded, reported to ensure confidentiality and privacy. So that's really the objective there. I hope it's clear that the idea here is that this information would be held confidential forever. And that's an expectation of the legislation for the MOU, for any entity, and also the capacity of any organization would be able to handle that.
Thank you so much. I really quick comment before we go to Senator Titus. I think in hearing your sentiments, now that we have established the opportunity to perhaps go through a subpoena, etc., I do share some concern that the way the bill is structured, you can have a faculty member or local entities that have no jurisdiction or training as to how they control the dissemination of health data, and you're walking a slippery slope with no particular parameters as to how that data is transferred, how providers have to respond to this. I understand the request for real-time access, but to me it sounds like you're trying to create a strike team for entities that probably is not the right position for them to be in. So that's my interpretation, but I'll let Senator Titus answer, or please proceed with your questions.
Thank you. Thank you, Chair. On the bill itself specifically, and I have a couple questions actually, Section 4, down to number 2, it talks about an opioid overdose fertility review is separate from any other independent investigations. And I'm wondering and worried if, when you have like a hotspot where we have sudden overdoses and suddenly you have people dying from overdose in a community, in a neighborhood, law enforcement gets involved with that right away. If you have fentanyl out there, especially now, we know it is a crisis. So I understand why you're here, because this fentanyl crisis is true, and we're looking for any solutions. And I agree, a rapid strike team for bad drugs, overdoses is really important, bad players out there. So I know that's the problem you're trying to solve, but I worry that in that particular section, perhaps it's opening and may even interfere with law enforcement investigations that they do. And it seems that statement about independent of, why would you even want to be independent of? Are you going to, is it attempt to make your own conclusions and not do it in conjunction with all the other people out there that are trying to solve this problem too? And then I have a follow-up.
Trade that for the record to Senator Titus. So strike team is exactly what we would love to have. That is the fully realized opportunity, that if there was and the reason that's important is because the prevalence of illicitly manufactured fentanyl creates hotspots, and then the ability to mobilize quickly is ultimately would be an excellent public health response. This bill, there is no one able to do that right now. This bill being enabling would then create the opportunity and the access point if someone could sort out all these details. So just for an example, in addition to meeting all the criteria outlined in the legislation, before an OFR could even launch, it is expected, and these are the standards from the Bureau of Justice Assistance, that they identify a governance committee and the administrative lead agency, identify who will be responsible for coordination, facilitation, data management, establish interagency data sharing and confidentiality agreements, recruit case review team members, ask member agencies and members to work out the data interagency agreement, set OFR ground rules and expectations, review data and determine case selection criteria, develop protocols for secure data access, provide team member training, set the meeting schedule. All of that would need to happen before the first request for information would occur. So this really is intended to create the opportunity, and if someone can do all this and then they can demonstrate the capacity to do these things, then they can go from there. So if this bill was passed today and signed by the governor, there wouldn't be hundreds of individuals going and requesting tons of information. And again, this is a very narrow purpose. It's interesting that you noted as far as like individuals or privacy or selective review. That was something that we discussed, and it was interesting. Let's say that an individual wanted to know why their child died of an overdose, or a law firm wanted to review a bunch of OFRs to identify people to sue or things to do. That's the other piece of this bill that's so important, is it protects that information from any of that use. It is for the public benefit. And I think that's important, because if those are your intentions to find someone to go get or whatever you're going to do, that's not focused on preventing this. And all of this really does demand that everyone who's participating is engaged in trying to do this. That was another reason to kind of move it away from the state, because it delineated who had to be what, and many people, me included, serve on committees that have no use. So the subpoena power also was interesting because, and I think it's carryover language. I would want to confirm that it's sort of carryover language. I think this would be an extreme case, because the whole point of all this is to establish collaboration and cooperation. And to subpoena, to have to go that route, I think that's a huge barrier. I mean, one, who's going to pay for the lawyer? The judge is going to have to figure this out. I mean, that seems like an extreme measure. And if we're getting to the point where that's what people are resorting to in order to get enough information, then we've missed the mark.
Just a follow-up to that, if I might, Mr. Chair. So again, I just have concerns about that section number 2 and 3, where the law enforcement have to, cooperate and all of that. And my final question is, I really worry about the access to the patient prescription monitoring program that we all have to sign on to. I have to look on it periodically and make sure nobody's filing false prescriptions. We passed a bill 2 sessions ago that allowed law enforcement to access that when they're investigating an overdose case. And so on the prescriptions and where the person got the medicines as a provider. So I wonder, do you foresee that this group would be able to access the prescription monitoring program, PBM, whatever? Yeah. So that took several legislative process to have different folks access that.
Trade Gillette for the record, Mr. Chair, through you to Senator Titus. The PMP is Nevada was innovative in 1995 with the implementation of one of the first PMPs in the country. Go Keith McDonald from the Pharmacy Board. That information is vital. Now every state has one. There's still improvements on the PMP data that are being addressed as far as certainly for example, it doesn't communicate with California. So it's real easy for someone to get a prescription and go across the border and get it filled. So there's things like that. Access to the PMP with law enforcement, one of the things that goes with that is the data integrity when it's reported by the dispensing pharmacy is solid. And then I think what you're referring to, there was a comprehensive opioid prescribing bill of 2017, which really addressed phase 1 of the opioid epidemic, which is overprescribing. So it mandated the queries of the PMP, it mandated certain reporting, and everyone had to register for it. So that is a valuable clinical tool. I will note that it's never been intended and was never designed to be sort of a surveillance mechanism or something that, in this state, for example, they're in contrast to North Carolina, and very specific. North Carolina Medical Board started proactively reviewing PMP data, and they would identify certain criteria, and it would spit out reports of doctors, and they would start doing investigations, and they did that. That's not possible in Nevada. For the medical board to initiate any action, they need a complaint. And so surveillance of the PMP has never been intended for that. It was always intended to be a diversion idea. The idea would be if you have 2 doctors who you find out that you're prescribing and someone else is prescribing, then the doctors have a conversation, and it's very informational. So it was always intended to be an instrument for others to act. And I went through that, and I hope that helps claim that this is developing an instrument that would help us understand what do these cases have in common? Is there anything we can do about it? And we will, like the dentist in India or in Indiana, I don't know about this, but this really is envisioning the development of a tool.
Let me just go back to the PMP again, because actually the data that we enter, one of the things we would use it in the hundreds of hours that I spent in the ER, we would quickly look up before I would prescribe a narcotic or pain medicine. Somebody comes in with back pain. It was a resource for me too to go look and see, geez, this person's had 5 prescriptions of these at different locations, and so I never really saw it as that they were monitoring me as much as I was able to know that this was doctor shopping or this person was going different places. But that was originally. Then it did allow, we did allow for law enforcement to access that. And so I just worry about an expansion of information if this board now has the ability to conduct its own review of the overdose. Will they have access to the PMP? Was that the next step on this board going to ask for?
Trade Gillette for the record, responding to Senator Titus. So all of that, as far as what data would need to be developed by the criteria, how are they going to select the criteria? What information is relevant? That would need to be hashed out, and then you bring the proper resources together. Then that would then have to go into this process of are we doing it because we're the state or local agency, or are we doing an MOU thing? So then there's another layer where all of that would have to be vetted out here. So the short answer is it's possible that might be part of a proposal, but isn't necessary, perhaps. With regard to, there was a bunch of studies on ER physicians specifically using PMPs, and that actually increased their confidence in identifying drug seekers or people they thought. If they did a query and they found that someone was doctor shopping or hospital shopping, then that was an issue. But if they found that they weren't, then they were more confident. So it was always a valuable tool in that regard. The other detail was the PMP morphine equivalency is also a huge issue. So the average doctor, if they're not living in the world of pain medicine, they don't really know the difference between micrograms of fentanyl and this, and the potency is all over the place. So Ohio actually came up with a system that when you query it, there's a big old number that comes up, and it's how much the patient's taking. So that is a very valuable tool. And so it was originally designed as a clinical tool, and then it had some diversion investigators at some point, and that was on and off, and then access to law enforcement was another detail. So that, I think, is really important. This bill kind of will live in situ until someone crafts an opportunity, that they bring these resources together, they organize how they're going to do in order to even begin this process. I think that's really important, that all that stuff would have to be detailed in first the demonstration of capacity in order to even begin this process.
Thank you so much. I'm going to have our legal counsel just clarify a few things for the record, please.
Yeah, Eric Robbins, LCB Legal, for the record. So, as far as Senator Titus's question about about whether one of these reviewing entities could access the PMP under the current provisions of the bill, I think that the answer to that is as simple as if it's an entity that can already access the PMP, so then it could, and if not, then the entity could not access the PMP. And so, basically, these entities that are authorized to do this under this bill, like Section 3.51A, like a state or local governmental entity, well, if that entity is going to be DPBH or a law enforcement entity, they have access to it. So then they could. And then kind of the same thing with the provider of health care. If it's a provider who's an authorized prescriber and can access, they would be able to access the PMP within the scope of what of their current authorization. But if it's like any other entity that's entered into an MOU, or if it's a governmental entity that doesn't have access to the PMP, then there's nothing in this bill that would give them access to that.
Thank you so much, Senator Stone.
Thank you, Mr. Chair. I appreciate the presentation. Most of my questions have been asked already, but I just got a couple. We've had almost 80,000 people die of fentanyl overdoses in the United States. I think roughly 500 in the last year in Nevada, and I don't know if they've been characterized as accidental overdoses or if they've been classified as suicides. We also take into consideration that, we have roughly double our population that visits the state every single month, right? And so I'll guarantee you that some of those overdoses are people that don't even live probably in Nevada. So if you see a hot spot of some type, let's say on the Las Vegas Strip, give me an example of what your response would be. I mean, are we just going to blanket the area with naloxone? I mean, how are you going to identify how to get to those pockets and make sure? I think you want to prevent these deaths. And I just was wondering that many of the deaths are people that think they're using heroin, and they're not using heroin, they're using fentanyl, and they're dying. How are you going to distinguish an accidental mistaken drug overdose versus somebody who truly wanted to commit suicide? And is there going to be conflicts, if you will, with the death certificate, or they go into the emergency room, they're dead, overdose? Is there going to be a conflict with the death certificate and maybe an ongoing investigation with the district attorney's office? And is there going to be a conflict there between you and the public safety agencies? There's a bunch of questions, I'm sorry, but.
Leslie Cohen, so it's enabling. So So even if there are a lot of deaths on the strip, it doesn't necessarily mean that that's going to be addressed. There has to be a qualified organization that decides to take this on. And as far as, do you want to talk about the conflicts? I mean, I don't think there's going to be a conflict there. I mean, no one's going to go back and change a death certificate or anything like that, because it's not about the people who have previously been deceased. It's about taking that data and moving forward and dealing with what's going on in that area and why are we seeing so many deaths in that area. And what can we do to prevent it? So if it is making sure that whether it's making sure that there's naloxone there, or training the dentists that are, giving prescriptions without prescribing it with naloxone, or whatever. It's just making sure that we're addressing things moving forward in that area based on the data that we have.
So are you going to depend on the medical examiner to basically I don't know if they're going to be able to have that much detail with fentanyl if it was an accidental death or if it was a suicide. We see so many fentanyl deaths out there. Do you think it might skew the data?
Trade you that for the record to Senator Stone. This process would not affect any other determination of death. So if the coroner issues a death, this won't reverse any of that. This is intended to prevent future overdose deaths based on information we learned from the collection of them. It's part of a harm reduction strategy. So, for example, in Clark County between 2018 and May of 2023, 46,000 overdose kits have been distributed. 4,984 individuals have been trained in its use. 236 trainings. Since the fentanyl test strips are available, 32 partner agencies work with the Southern Nevada Health District to distribute 48,000 fentanyl test strips. This is so that people can test their stuff before they use it. It's too important that the public safety, public records work continues unimpeded. This is a way of engaging in the process, not interrupting it, but gathering information that is actionable to prevent future deaths. It's really important, I think, because like the quality of care that a healthcare provider can provide when they know everything they need to know about a patient, without judgment, that's a critical detail. This process is not intended to judge anything. It's intended to find out what is going on and then to respond as they're able to. So I hope that responds to your question.
Leslie Cohen, if I can. And I take your point about suicide, but for instance, let's say there's a regular street fair that occurs once a month, every other month, something like that, and there starts to be a lot of deaths around that time, and maybe the right people who have this, get this data and are able to use this information to see that it's kind of happening around the time people going to this fair. I mean, maybe they'll be able to use that data and realize, well, it's probably not an overdose if you have a bunch of people who are hanging out at a festival that's, probably that wasn't, those weren't intentional suicides that were happening in that area. But that's why they're going to need the data to try to figure that out.
Okay, I appreciate that, and I appreciate all the intervention programs you're talking about with the kits and the fentanyl strips, and if we have areas of Las Vegas that maybe aren't on the strip where we're seeing these spikes, hopefully we can give people the tools so that they can help themselves identify these dangerous drugs and their potential to kill them. So, but I appreciate you bringing this forward, and I just hope that it just seems to be a lot of moving parts, and I'm anxious to hear from the public safety agencies if they see any impediments to their abilities to solve some of these crimes as well. But thank you.
Thank you so much. And to my colleague from Southern Nevada, and to his comments, I think it's appropriate to have conversations as to what response mechanisms can look like in terms of surveillance, right? We talk about that in public health, but I think the key part is review boards kind of come post of the encounter, and a lot of that probably could be solved if we just fix the infrastructure in general. And so I think that's probably a discussion that's well worth having. But we'll go ahead and open up to testimony in support. So if you're in support of this bill, if you can please come forward. So folks can line up.
Thank you, Chair. John Pirro from the Clark County Public Defender's Office. I want to thank Assemblywoman Cohen and my friend Trey Delap for bringing this bill forward. I understand there's some issues. The county is going to bring up some in the opposition. I will say, though, that we've heard a lot about fentanyl all session. It's probably one of the biggest trending topics of the session. This bill is seeking to get us data so that we could move forward in a data-driven way that could perhaps guide us better than some other measures proposed this session. So with that, we are in support.
Good afternoon or good evening, Erica Roth, ERICAROTH, on behalf of the Washoe County Public Defender's Office. I'll simply echo the sentiments of my colleague from the South, and we are in support of the bill. Thank you.
Anyone else here in Carson City or in Las Vegas? BPS, anyone virtually?
If you would like to testify in support of AB 132, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Let's move on to opposition testimony. So if you are opposed to this bill, please come forward in Carson City and in Las Vegas. And please begin.
Good evening, Chair Donate, members of the committee. Joanna Jacob on behalf of Clark County. Here in opposition not to the intent to address opioid abuse in our community, but more so on the workload concerns that we have after reviewed the first reprint. We did monitor this bill on the Assembly side, and we were aware that there were conceptual amendments, but obviously we came to this bill sponsor when the reprint came out once we saw how the bill was structured. Specifically, I guess our concern is that collectively between Clark County and Washoe County, there are two corners that cover the entire state. And that is the nature of the work. There are several bills proposed this session that are adding additional review committees, Senator Donati. So these are probably heading your ways at some point, but AB 119 is going to add the review of elder deaths that are suspected of, and if an elder citizen passes away with suspected maltreatment. Also, Assemblywoman Thomas, who was here before, is proposing a fetal and infant review that is in addition to our child death review, suicide review, and other review committees already existing in statute. We shared listened to the discussion very closely, but I think the way that we are reading this, and we had talked to the sponsor about perhaps trying to set some parameters around the scope of who can conduct the review committee, where we are reading this, even though it may not be the intent, but that there could be multiple in our county. And though I know that there is some doubt as to that will actually happen, it is enabling to allow a number of entities, a state or local government entity, obviously that's us, but a hospital, a provider of healthcare group, a faculty member, student. We have a number of institutions in Southern Nevada. We have a lot of people who want to work on this issue, and so we are a bit concerned that we may be juggling multiple requests at one time, or from specific entities. So we'd like to see some parameters around that. I believe, I guess I will be, I know Senator Titus, in response to your question about Section 4, subsection 2, about the review is separate from and independent from, in addition to the investigations that we do. The coroner investigates every death, but we also do the investigations for law enforcement. So we are responding to everything, and I think that's where we are a little bit concerned about the timing of these requests. Obviously, the stated testimony that we want to get to as close to real time as possible. I know my colleagues back of me are not going to come forward and testify, but I will say that they have said to me that they know that our coroner's office is very understaffed at the moment, and there is delay in getting the information to law enforcement and to and it's just the nature of, unfortunately, in Clark County, we have seen a drastic increase in overall deaths. So there's been a lot of discussion about fentanyl, 126% increase in fentanyl deaths, 32% of all overdoses just in the last year increase, and 31% in suicide. So we are struggling. And I think we will continue to work on this. I think but that's what I would like to see is maybe some parameters around what that would be. And I will concur in the testimony that Washoe County is allowed, because we tried to split it up between Washington from our concerns based on the counties. I guess one other thing I think I was going to mention is it's not just the coroner, but there's also, we believe there could be county impacts because there is the request to look for social service agency data and child welfare data as well. So it is something that we contemplate having to enter into a number of MOUs, and that is a concern. Thank you.
Good evening, Mr. Chairman, members of the committee. For the record, my name is Cadence Matievich, representing Washoe County. And we too are here in opposition to the implementation components of the bill. We understand that this is an issue that we have to address in our state, and local governments are absolutely committed to being part of that solution. We just have some concerns with this particular proposal, and we would like to thank Assemblywoman Cohen and Mr. Delap for the time that they spent with us yesterday, and we remain committed to continuing conversation with them. I will, Ms. Jacob enumerated a number of concerns that Washoe County has with respect to the public records request for our medical examiner's office and other departments within the county. In addition to that, we do share we do have some concerns, and Senator Wynn, I appreciated some of the questions that you asked, that it contemplates that any entity that enters into a memorandum of understanding with the local government entity, and then it puts certain requirements that the state or local government shall not enter into these MOUs until it's verified these things. And Mr. Delap gave a really long list of I think, some important things that would need to be reviewed, but that places that burden on the local government to conduct that review before entering into that MOU. And if in that diligence we overlook something, we think that there's potentially liability for us. It talks about transferring and copyrights or intellectual property that's gathered in the course of these reviews to the local government, and that we then have to maintain that. And that's not something that we currently do. We would have to contemplate, how long do we keep that? Where do we keep it? And so I think there's just a number of additional burdens that this places on local governments that's concerning for us. So I appreciate it. Thank you.
Thank you, Mr. Chair. Vincent Guthrow for the record. Last name is spelled Gutreau. I'm the Executive Director of the Nevada Association of Counties, or NACO. Just first off, I want to thank the sponsor for offering to continue the dialogue after today's hearing. We support at NACO all of the comments made by Clark and Washoe and echo their comments as well, and then add in our piece on the county impact. Every county provides human services through those human services individuals, and that section 4.3E would provide, I think, an undue burden on us to implement this. So with that, I'll save us on some time and just say we're also in opposition. Thank you.
Thank you so much. If there are other folks in opposition, please come forward. Seeing none, is there anyone in Las Vegas? And BPS, anyone virtually?
If you would like to testify in opposition to AB 132, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Let's move to neutral testimony. If you would like to testify neutral, please come forward. Anyone in Las Vegas and anyone virtually.
If you would like to testify in neutral for AB 132, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Assemblywoman Cohen, do you have closing remarks?
Thank you, Chair Leslie Cohen. Thank you, committee. We appreciate the robust conversation. We will continue the conversation with the counties and hope we can come to something that will be helpful for the state.
Thank you so much. We greatly appreciate it. We'll go ahead and close the hearing, and that brings us to our last agenda item, public comment. Anyone here in Carson City, Las Vegas, and virtually?
If you would like to provide public comment, please press star 9 to take your place in the queue.
Good morning, Chair, or good afternoon, Chair. This is Dora Martinez with the Nevada Disability Peer Action Coalition. I was actually trying to call in support of AB 132. It's going to be really quick.
Please proceed.
I'm so sorry. Okay, come here, Sarge. We want to support AB 132, and we understand that there's needs to be more discussion. People with disability are a victim to these fentanyl overdose and veterans too. So we appreciate the amazing, awesome, remarkable Assemblywoman Cohen for sponsoring AB 132. And thank you and have a great night.
Thank you so much. BPS, anyone else?
Chair, there are no additional callers at this time.
Thank you so much. That concludes the business of today. For the folks in Carson City, it is Cuatro de Mayo, so we'll have an event across the street, and we invite everyone to attend, and the meeting is now adjourned.